This presentation will discuss the choice of manual therapy technique as well as grade in patients with cervical dysfunction. We'll also present the literature evidence supporting the use of manual therapy for the treatment of patients with mechanical neck pain. Manual therapy techniques are utilized mainly for the treatment of mobility restriction, and so that will be the focus of this presentation. So we have several groups of technique choices for the patient with cervical restriction of mobility. There's soft tissue techniques and functional techniques, which focus more at the muscle and tissue around the joint rather than the articular glides themselves. Manual traction is often one of the first techniques that we'll choose, considered one of the most gentle treatment techniques to start to try and stretch around the capsule and unload the articular surfaces. There are also a group of passive mobilizations. We can use the PIVM type movement, incorporating physiological movements, or PAVM type movements, which are the accessory glides with either a Z joint or a U joint focus. NAGs are also passive mobilizations that are presented by Mulligan, and we will have a look at those as well. There's also the group of active mobilizations known as muscle energy techniques, which are osteopathic techniques that incorporate voluntary muscle contraction to assist in the mobilization. And you would also probably consider SNAGs and SMWAMSs, which are spinal movements with arm movements, which again are Mulligan techniques that incorporate active involvement of the patient. Obviously, exercise, although not a manual therapy technique, is an adjunct treatment that we will use to maintain the mobility that we gain with our mobilization technique. We mustn't forget also mobilization manual therapy techniques directed at the neuromeningeal system, both sliders and tensioners. So this is a wide range of choices that you have to approach your patient with lack of mobility in the cervical spine. Now there are two main grading systems that are most classically used, that of Kaltenborn as well as Proleven, more commonly used, that of Maitland. If we look at Kaltenborn's, he divides his grading system into 3 stages, 1, 2, and 3. In stage 1, he calls it loosening. You're just separating the joint surfaces before R1, so there's no resistance, and it really is just a gentle unloading of the joint surface. In stage 2, he suggests that we take up the slack, so you move between R1 and R2, so you're well into the resistance, but not right at the end of range. Stage 3 is a stretch which attempts to move R2 further into the range. His grading system is classically a sustained movement rather than an oscillatory movement, which is what we're more familiar with the Maitland system. So Maitland grades from 1 to 5 oscillatory type techniques, although grade 5 is a manipulation technique. In grade 1, it is a small amplitude movement early in the beginning of the range. Grade 2 is a larger amplitude, but it stays before R1, so there should be no resistance to the movement. You should feel no stretch of tissue around during that mobilization. Stage 3 is large amplitude moving into the resistance, so between R1 and R2. And grade 4 is also into the resistance, but a smaller amplitude. Grade 5 is the high velocity, low amplitude thrust at the barrier, which we refer to as a manipulation technique. So let's start by describing the original grading system on the movement diagram. So if we look at this movement diagram, A is the beginning of range of motion, and B is the normal physiological full active range of motion, or passive range of motion in this case. In this particular joint, R2 is the end of range for this joint, so it would also be considered L, or the limit of movement. So the grading is related to A to L, which would be the amount of available range of motion at this joint. So if we look at the first resistance, R1, which is sort of partway through this joint motion, we can grade the grade 1, which is at the beginning of the movement, small amplitude, and grade 2, which is a larger amplitude, still prior to R1. So it should not be pushing into or past R1 at all. So when you're doing these grades of movement, you should not be feeling any resistance within the joint, not feeling any stretch. These grades of motion are used only for their physiological response. There is no true mechanical response within the tissue, other than perhaps some sort of fluid exchange process. But there's no stretch of the capsule in those two grades. So then if we look at grade 3 and grade 4, they are movements that are within R1 and R2. Grade 3 being large amplitude and grade 4 being small amplitude. The grade 5 movement is a thrust, high velocity, low amplitude thrust at the limit of range, trying to push that limit further toward the normal physiological movement of B. So this was the original grading system that was used for years, but I think people found that that there were some limitations here, or that clinically we were using something a bit more sophisticated than that. 3 did not always move all the way between R1 and R2. Sometimes it was closer to R1 and moving around R1, and other times it was sitting closer to R2, but still large amplitude rather than short amplitude. And there would be times where you'd still do a short amplitude movement, but not push R2 quite as consistently because of the amount of discomfort, say, at R2. And so a modification of this system occurred using minus and plus to denote the position of that oscillatory movement relative to R1 and R2. So if you go back and look here, grade 1 and grade 2 are still sitting in the same part of the range prior to R1. You can take grade 2 and make it more a grade 2 plus or a grade 2 minus. You could do the same thing with grade 1, but these are very small movements prior to that R1 occurring in the range. And so clinically, there isn't as much need for modification of these two grades. It is more the grade 3 and the grade 4 that we found were amenable to a change in the grading system. So if you look at grade 3, originally grade 3 would be a large amplitude between R1 and R2, and the grade 3 currently, that doesn't have a minus or plus, sits in the middle of the range, large amplitude between R1 and R2. But we have a 3 minus that straddles the R1 line, so it's still large amplitude, but it's earlier in the range. And then we have a 3 plus. So this is a movement that is truly pushing R2, trying to force that limit further into the range, but it is large amplitude. And then if we look at grade 4, you can see again, here's a short amplitude movement in the middle of the range between R1 and R2. You can move that short amplitude grade a little closer to R1, and then you have 4 minus, or you can take that short amplitude movement and move it further into the limitation, and you will then have a grade 4 plus. So here you'd be doing a short amplitude movement impacting the limit, the R2, and trying to push that further into the range. A grade 5 technique is unchanged from the previous system. It's still just a short amplitude, high velocity thrust at the barrier to movement. So this is the system of grading that we will use throughout the course, and this is the system that is currently being taught in Canada. If you want further reference to this, there was an ODR article that was written and presented several years ago that you can get access to. So let's first discuss the clinical scenario of where pain is greater than resistance. To be able to choose what type of technique and what grade of technique we should use, we have to think about our movement diagram, think about our patient's presentation, and choose appropriately. So if we take the situation where pain is greater than resistance, where pain is the main consideration, that movement is actually limited by P2 rather than R2. And there may be an R1 in there prior to P2, but really P2 is your limitation of movement. These type of joints generally are more irritable. There's often muscle reactivity or guarding present at that joint, and they may have severe pain or even pain at rest. So there are several items that we have to consider when choosing the technique and the technique approach for treating this painful joint. First of all, the position. So if you have a painful joint, you should be choosing the resting position or the neutral position of that joint so that it is the least painful position for that particular patient. And then from there we add the other components of our technique. The strength obviously should be gentle. The grades we use are need to be within a pain-free range, so they'll be generally grade 1 or grade 2. If you choose traction as your technique, you can use a stronger grade as tolerated, and you may in that choice use a sustained type of technique rather than an oscillatory. But grade 3 or grade 4 traction, if it relieves the pain and the joint is not reactive to that, would be an appropriate treatment choice. If you went to use grade 3 and you encountered some reactivity around the joint of the muscle, you would back off to the grade 2. So it would be totally dependent on how the joint reacted to your grade. The speed generally will be slow because you are needing to monitor that pain response. And the duration initially would be short, 30 seconds worth of technique, then reassess, and then you might repeat that 2 or 3 times. The type of techniques that are used, we have mentioned earlier that traction is probably considered the most gentle of techniques. There's often at a joint both traction and distraction. Long traction, axial traction through a joint isn't necessarily pure distraction, so you might have to make a choice there. We can use functional techniques or muscle energy techniques, particularly to address any muscle reactivity around this joint that's painful. And then we could still use a PIVM or a PAVM type technique in that grade 1 or 2 choice. Generally in the spine we would use flexion before we use extension, as it tends to unload more of the joint surface, whereas extension may be considered some compression. But again, that depends on the particular patient. You'll sometimes find that PAVM type techniques, glide type techniques in the spine are a little too pokey and tender in these patients with pain, and the PIVM might in that case be a more appropriate technique. So now let's move to the patient where resistance is greater than or equal to the pain. So now both pain and stiffness are present, but the pain isn't just the predominant factor. So there can be different types of relationships between the pain and the resistance. If pain is equal to the resistance, then you'll likely have to move a little bit into that resistance in order to be effective. But if pain is still quite dominant, then you have to monitor and respect that. So these techniques won't necessarily always be pain-free, but it will depend on the irritability of your joint picture as to how much you can start to move into, at least into R1, maybe not. Okay, so let's look at the parameters that we need to consider with this type of patient. So if we look first at position, we will see again you're still using the neutral pain-free position initially, but you can start to move just into the physiological range that is limited without really moving too far into that range, definitely not moving into the absolute limit of that physiological range. The strength now starts off gentle, but as you progress into the range, you may increase the strength, and you may cause some post-treatment soreness, which you will have to monitor and decide whether or not it is acceptable or not. Still respecting pain, you can move from a grade 2 into a grade 2 plus, so that you're going to push just at the beginning of R1 and progress into either a 3 minus or a 4 minus, so either a large or a small amplitude range oscillation closer to R1 rather than moving toward R2 because you still have a pain feature in this joint. The speed would start slow, but you may move into a more moderate speed as you are able to move further into the range. So now we can start at about a 1 minute treatment, progressing up to 2 minutes, and again repeat this 2 or 3 times, reassessing in between. The type of technique is similar. We can still use traction or distraction for this group. We can use the accessory or physiological movements. Generally, we'll choose whichever has the greatest pain-free range. You can also use the NAGs, Mulligan's NAGs, in this scenario. There's still a pain portion, and there may still be muscle guarding around this joint, and so muscle energy techniques would still be effective, and snags might also be able to move that resistance and control the pain as the patient actively moves through their range. So now what about the patient where their predominant feature is resistance? So this is where stiffness is the main disability rather than pain. Pain is just a minimal component. So here, R1 and R2 are the most important factors because pain is not a main feature. This is an end range problem, and so techniques are aimed at stretching these stiff structures, and because of that, it may cause discomfort. So here you're thinking about your frozen shoulder in the inactive phase where there's little irritability and you're just trying to regain the end of range. And you may expect some post-treatment soreness, and without that you may not gain range. You educate the patient about that, have them monitor it, and decide what is an acceptable amount with the particular patient. So again, let's look at our parameters here. So if resistance is the main or almost only feature, and you are trying to stretch out the end range of a joint, you must be moving into the resistance toward the end of range of that joint, and you may be incorporating all the conjunct movements at the end of that range. Strength now is firm, and that is the only way that you're going to improve this end range problem. Our grades now have to be pluses, grade 3 plus or grade 4 plus, because we have to be pushing R2. And you can intersperse these with grade 3s, moving back out of the range a little bit and doing some amplitude oscillations to try and decrease the amount of discomfort. Again, as we mentioned before, treatment soreness is to be expected, and we monitor that. The speed here may be fast oscillations, or you might slow it down and sustain these stretch movements at the end of the joint range, thinking of trying to stretch out that connective tissue. Our duration is much longer, 3 to 4 minutes, repeating that 2 to 3 times. Again, depends on our effect and how much treatment soreness the patient has been reporting. So what about the choices of technique? Here, physiological and accessory movements. Really, they are the passive end range glides. You often have to incorporate the combined movements of the physiological movements as well as combining any of the accessory movements that are involved at the end of that range. Muscle energy techniques are probably not that appropriate at this stage, other than as a recruitment or motor control type of technique, but to gain range, muscle energy technique goes to R1 and tries to move R1 along. In this case, we are looking at R2 and pushing the limit. Nags and snags are still appropriate treatment choices for this type of joint. So let's look at the literature on the clinical effectiveness of our physiotherapy techniques, particularly in treatment of neck dysfunction. There is strong evidence in the literature to support a multimodal approach to treatment of the patient with cervical dysfunction. That would include either mobilization or manipulation along with therapeutic exercise. This is true for both subacute and chronic neck pain patients and has been shown to be effective in the long term. They have found about a 28 to 70% advantage using this multimodal approach as compared to controls, with a long-term absolute benefit of a decrease in pain of 25 millimeters on a numeric pain rating scale. There's also moderate evidence for some other treatment approaches. Exercise, there's strong evidence when used as part of the multimodal approach, but only moderate evidence when exercise is used as a sole approach, as a standalone treatment. Laser has been shown to have an improvement in pain for the intermediate term when used to treat facet joints. Electrotherapy, there have been some moderate evidence for immediate post-treatment effect, mainly in acute more than chronic patients. So that doesn't mean that electrotherapy is not of benefit, especially in our acute WOD patients, to decrease post-treatment soreness, to control a bit of pain so that they can then do their exercises. But you'd have to consider whether or not in the chronic situation, whether or not there is much of evidence supporting the use of electrotherapy. For mechanical neck pain, traction has been shown to have short-term benefit, but there's some inconsistent evidence with patients, the patient subgroup of radiculopathy. A couple studies have shown a very strong effect, and others have shown a lesser effect. So in the systematic reviews, there's only moderate evidence. Acupuncture shows only an immediate to perhaps short-term effect for pain only, not for function. So again, as a modality to treat short-term pain, that may be of benefit as an adjunct to other treatments, but not as a standalone treatment. There are several things that have been shown to have evidence of no benefit, and that would be home exercises alone, so just being given a home exercise sheet. Again, as a standalone treatment, we all use home exercise as part of our exercise program that we teach them in the clinic along with our manual therapy. No benefit with hot packs, as well as with electromechanical stimulation and ultrasound. So the reference for this is Gross et al., an article in 2007, and then